It's my pleasure to introduce Kate Hamlin. She's a child life specialist from the burn unit, and she's going to go over developmental stages that are important to us about children, and she'll tell us a little bit about what she does in the burn unit. So please welcome Kate Hamlin.
So I work on the burn unit. I'm there 4 days a week, Sunday, Monday, Tuesday, and Thursday. Originally it was very long days, 2 days a week, and we realized that that wasn't going to work. Basically, my entire job is to make the hospitalization process as least traumatic as possible. Being that it's burn, being that you guys are trauma, that's kind of, an oxymoron. We'll see how that actually works, but what we do is we try to make sure that every kid is prepared for everything that's going to happen to them while they're there. We can't necessarily prepare them for what has already happened to them to bring them to us, but we prepare them for everything going forward. We let them know every step of the way what's going to happen, and if we have any time, like if we know there's an upcoming surgery or something like that, we prepare them for that procedure enough as is developmentally appropriate in advance. Children respond to their world very differently at different stages of development. Developmental age plays a key role in determining the child's psychosocial needs, level of understanding, coping mechanisms. The interactions among such factors affect the style and methods of care most suited to the specific needs of each child. So everybody that has a child knows that every child is very, very different. What will work for one kid won't necessarily work for another, but tailoring that to what we kind of know as a generalization for the developmental needs of that age group is what will get us a good start. Infant is trust versus mistrust. Infant needs maximum comfort with minimal uncertainty. During infancy, a child learns whether or not they can trust people. They either will rely on them to provide for their needs, or they will learn that no one will provide for their needs, and they'll learn to self-soothe. This leads to lots of issues later, but that's the basis of infancy. Everything in an infant is sensed as either pain or pleasure. So especially with you guys where you see them coming in from some sort of trauma injury, it's kind of crucial that for every painful thing you inflict on them, you try to balance it out with something pleasurable, like rocking, soothing music, physical touch, something that can counterbalance that pain, because that's all that they're sensing. They don't really understand anything in the middle. There's no gray at this point. Infants are able to recognize familiar faces. They use crying body language and their tone of voice to convey their wants and needs. They derive pleasure from feeding, being held and rocked, and tactile stimulation. So sometimes even if you've done something painful or if something painful has happened to this child, even just changing something that they feel on their skin, like getting a different sensation of a different blanket, something that's pleasurable but different than what they've already been in, so their brains can acknowledge the change. As much continuity of care as possible. If you're the nurse in the beginning, if you could stay their nurse throughout, that's very, very helpful, especially if there's no mom, dad, caregiver. They develop social behavior, greater autonomy and independence. They like dramatic and imaginative play. This is the age where regression is at the higher risk. You could see a 4-year-old that is suddenly acting like a baby again, like they aren't telling you they need to go to the bathroom, they're just wetting themselves, like things like that, because they go back to the place where we're most comfortable. And if they're 4, it's usually infancy, where they're wanting to be held, they get really quiet, they want to be rocked, things that they maybe mom and dad might say, oh, he hasn't asked for his pacifier in a year and now he wants it, that sort of thing. School age is industry versus inferiority. Child tries to develop a sense of self-worth by refining skills. They are learning to be productive and competent. Children at this age still need a caregiver in times of stress and may be unwilling to ask for help. So this is a case where you're going to have to sort of ask them. Like if you can sort of sense that they were wanting something or needing something, you offer it or ask for it. It's kind of, you have to take that little bit of step because they won't go out of their way to ask you. Success contributes to positive self-esteem and self-control. So telling them they've done a good job when they've gotten through something is huge at this age. And they're establishing same-sex peer groups, and it's becoming very important. So in this case, if you have like a 9-year-old little boy, if there is a male nurse, huge. Like that'll be huge. They're more likely to open up to them. They're more likely to be comfortable with them and sort of bond and feel like they can get through it. It's not, crucial all the time, but if it's there, it's a really good tool. They're beginning to think logically. They're able to understand prognosis and diagnosis. So when talking around the child, if it's something that you're not comfortable with, the family's not comfortable with that child hearing, leave the area. Don't just pull aside, because they will hear it and they will apply it to themselves, whether or not it's about them. So they'll pick up on what's being said. So even if you're talking about a patient that may be in the next bed and they can hear it, they may interpret it as they're talking about me. This is about me. I'm going to get this procedure, and by the time you come back, they're having a meltdown when all they maybe needed was stitches, but now they're convinced they need surgery because the person next to them does. That sort of thing. So kind of becoming more aware of yourself and what you're saying and doing. Adolescents, so they're in the place of identity versus role confusion. They're trying to integrate as many roles into their own self-image under role models and peer pressure. They are beginning to wonder who they are, what their place in society is. They're transitioning from childhood to adulthood and are acutely aware of body appearance and imperfections. They may view illness in terms of change of appearance and function more than anything else. So you may be saying, this is going to mean you're going to be out of school for 6 weeks, but all they're hearing is, I'm going to have to wear this ugly cast, or I'm going to have to do. They're not really perceiving it in terms of medical, they're perceiving it in terms of what people are going to think. They're aware of the psychological, physiological, and behavior causes of illness and hospitalization, so they know why they're there. So the related fears, and this is kind of the most important part of all of this. An infant who's you have in your care, their issues are going to be with attachment, separation from primary caregiver, and stranger anxiety. So if you have a situation where mom's not available and you're doing things to this kid, it's like anxiety central. You've taken all of the things that make them uncomfortable and you've put them into one. Now it's unavoidable, but this is where that keeping the same caregivers consistently while you're doing all the procedures and whatnot are very important. They can become difficult to console. They may display a decrease in appetite and loss of interest in familiar toys and objects. Toddlers. Their biggest fear is the disruption of routine. Now, they don't really have a concept of fear like you and I have, but the biggest thing that's unsettling to them is the disruption of routine and separation from parents. A loss of physical control. Toddlers will become aware of cause and effect and can begin to think if you hurt them once, you'll hurt them again. So if you come in and all you've been so far has been someone who's done things that have been painful, that's who you are to that child at that point. So you're going to have to either find a way to balance it or just make peace with yourself that you may never be this child's friend in their eyes. It's not about you, it's about them. But they will put that, they will say that, you come in and this is what happens. And we'll see this upstairs all the time where they even see anybody in a white coat and or scrubs are more than anything. Then it's, you did this to me, everybody in that blue outfit has hurt me, I don't like you, I don't trust you, come back when you're wearing something different. And preschoolers, their big things are, loss of self-control, loss of body functions. If a child is wet the bed and then we've put them back in diapers, it's not great for them. They're not. It really sets them back. They have fear of the dark, further injury, changes in their bodies, like the kids that we have that have donor sites. It throws them for a little while. That what is this and why, and the fear of the unknown, a fear of abandonment. Again, a constant caregiver is huge. They will often regress to infant toddler when they're stressed. School-age children, pain, bodily injury, death, loss of control, loss of privacy, death of other patients on the unit. Become acutely aware again, like they think of this person is sicker than me, is this person going to live? It becomes very wrapped up in their head about other people on the unit or other people on the floor. They will give you nonverbal cues. They'll stop talking, they'll be overexcited. They'll be jumping around, being hyper when they haven't been. Things like that where are not the norm of what you've seen. You can tell when their anxiety is really high. And they're able to understand the surgery and medical treatment outcomes. So if you tell them, we're doing this for this reason, in a developmentally appropriate way, they can register that and they will, take that and process it. Adolescence, loss of control, fear of altered body image, fear of loss of independence, invasion of privacy, so that's huge, disconnection from friends, and they're worried about their appearance. They're self-centered. Changes in their bodies are issues of great importance, and they believe in their own unlimited powers. So when you have a kid that's come in because maybe they took their dirt bike and tried to jump over something that they shouldn't, and now they're here, the fact that they got hurt sometimes doesn't register. Like, how did this happen? Like, I should be able to do this. I can do anything. Nothing bad can happen to me. So a lot of times when they're first, like when you guys first see them, they're processing with this, like, how did this happen? Like, nothing bad's supposed to happen to me type of thought. So they have that belief in their own unlimited powers, and it kind of becomes challenged when something bad happens. So coping in infants. Whenever possible, don't do the procedures in a child's crib. That doesn't really apply to you as much as it does up on the unit, because we see them every day, like continually. You just don't, that in an infant's world, the crib is their entire world, so if you are applying negative stimuli in a safe space, it just throws off their concept of that they're safe. Encourage cuddle time after a procedure. A baby will begin to associate a brief period of pain with a lengthier, happier one-on-one time with a caregiver, and that doesn't have to be mom or dad. That can be any of you. Encourage parental involvement. Always use a soothing, calm voice. Support the infant's developmental needs by giving stimulation, example, rattle, musical toys, etc. Ask parents for established coping techniques. They might have some weird, fluky thing that works really great, and use it. Position the infant in a comforting manner during the procedure, not flat on their backs. Research has shown that this is the most detrimental thing that we do. It's easy for us to get at them, but pinning a child on their back and having them be vulnerable in that way is not good. Sometimes it's unavoidable, especially depending on where the injury is and what caused the injury and all of that. But for IV starts and things like that, having someone hold them, having them on their side, things like that, for any time you can have them where they can sort of protect this core, it is really, really beneficial. And with IVs, a lot of times, I went up to Shriners. I don't see a lot of the kids getting IVs. They usually come to me because you guys have done it first. But they have the kids hug the caregiver, so the arms are behind mom's back, the nurse's back, whoever, and they'll put the IV in that way. The kid knows what's happening, knows what's going on, but is completely distracted and has that center part of them, that vulnerable part of them, up against another person, and they're comforted. So they may still cry, but that meltdown thing doesn't happen as much, and the long-term effects of you stab me with a needle, I'm never speaking to you again, are a little bit diminished. Coping in toddlers. Give a toddler the opportunity to develop emerging independence. This is great. If you can use them while you have them, say, if you hold this for me, this is your job, do this. They will do it, and they'll take a great deal of pride in doing it, and you'll be able to get more done because they're doing their job while you do yours. And you can even assign them a job of, your job is to hold your arm really, really still. And 9 times out of 10, kids, if they're not in panic mode already, now if you've already gotten them and they're panicking, some of this is not really going to help because the ship has sailed. But if you get them when they're not panicking, you can sometimes even get them to hold their arm still for something painful because they are so, their self-worth is so wrapped up in doing a good job. And you just reinforce that they're doing a good job that whole time. Provide familiar toys and play opportunities. Give choices. Now, upstairs it's a little different because we can say, do you want to do your dressing change before or after lunch, things like that. With you, it's a little different. It's what, juice do you want, what color bandage do you want, things like that. But giving them options gives them back a little bit of control, even though, they don't have a whole lot. Provide medical play. If there's anything, anesthesia mask, oxygen mask, anything they can play with that they're going to be seeing that's terrifying, let them have at it. That's huge. I had a kid that was 5 years old and had open heart surgery when he was 3, but he was here for a burn, and he came up and, he had by the end of his visit a design for a more comfortable oxygen mask. Like he had decided that if you just took the puffy part from around the anesthesia mask and then you made this size, and he had a whole design that he gave to Dr. Potenza. So, you know, letting them feel that sort of sense of mastery and empowerment and things like that, and familiarity, so they come to, you know, see things as something they know and understand rather than something scary that's happening to them. Consistently reinforce that they've done nothing wrong, especially in this age group, because they view pain as punishment. Resist telling them to be a big girl or a big boy. I'm really hard, and I catch myself sometimes doing that, because you just want to be like, you're a big boy, you don't want to act this way. That is like cardinal rule number one, don't do that. It becomes something they feel shamed about. Instead of an empowering situation, now they feel like they've done something wrong, and they've disappointed you. Continue with the routines as much as possible. Provide structure and limits. It's tempting to let the kids sort of scream at you and say horrible, hateful things because you feel bad that you're doing horrible things to them. But there's a limit. I say upstairs that you can scream and holler, and if it's painful, you cannot scream and holler at me. You can't be hateful at me. Like, we're not doing this to hurt you. You can scream if it's painful. You can't, you know, yell at us. We don't know what's acceptable in their homes, but having a 5-year-old swear at you is not appropriate. So we don't allow that. And we do redirect it. So coping in preschoolers, provide an environment where a preschooler can continue to develop independence, again with the helping, like let them help you. Provide medical play sessions, encourage parent to stay with the child, encourage sibling interaction whenever possible. A lot of times it's not the parent, especially in some of our like bigger families that we've seen, that it's not the parent that's comforting, it's the older sibling. So allowing that older sibling to be present, if possible, is sometimes very, very helpful. If a child regresses, allow it. Don't punish the child for this behavior. And another thing which I didn't put here is if a child regresses to a different developmental stage, you now have to relate to that child at that developmental stage. So if you have a 10-year-old acting like a 5-year-old, you now have a 5-year-old. So you're not trying to pull them out of it. You're not trying to make them be 10 years old again. You are now relating to them where they're comfortable and where they're feeling safe. So that goes in hand with that don't be a big girl, be a big boy thing. You know, if they've regressed and this is their coping mechanism and this is what they're doing right now to get through this moment, you have to go meet them there rather than pull them up to where you want them to be. Ask the child about previous hospital stays and clear up any misconceptions. If they're school age and they had something happen when they were a little kid where they were in ER, between that point and this point, who knows what they've come up with about what actually happened and what they've concocted in their brains is what they think was the reasoning and what awful things happened. And something really, really stressful that happened when they were 4, maybe something that would not stress them out now, but they've now put it in their head that the hospital and nurses and doctors are bad and it hurts and all this stuff. So if you can find out if they've ever been in the hospital before, you can kind of correct any of that. Frequently encourage them to ask questions. It may seem like you're beating a dead horse, but you'll ask 25 times, and that 26th time, that kid will have a question. It always, always happens. Allow the child to make choices whenever possible. Provide privacy. Don't assume because they're a kid they're not going to care that they're naked on a table in front of 5 adults. They will. We had a bunch of medical students come into the tank room when an 8-year-old was having a bath, and they all sang happy birthday to her. And she was sitting there naked and coming to terms with the fact that she had significant grafts and things like that. So her body image was already wobbly. And they walked in and started singing to her, and she was just like, are you kidding? Like, she looked at me, and I was like, I'm so sorry, I don't know what to do. Like, at that moment, I was at a loss as much as she was. But yeah, so you have to assume that they want privacy as much as you do. It may be different, but just be as sensitive to that as possible. Encourage socialization between hospitalized children. This is probably not something you'll run into. Tell them the truth at all times and only promise what you can deliver. If they ask you if they're going to need any more needles, don't say no if the answer is possibly yes. You can say, I'm not sure. That's okay. You don't need to necessarily have a concrete answer, but saying this is the last one to get them through that one is not fair to the person who has to do the next one, because it will not go well. Children do really, really well when they're told the truth and what the expectations are. Not to say they won't be upset when it has to happen again, but it'll be much less than it could be. Teach the child about the procedure and allow for questions. So rather than just run in, I mean, you may not have ample time to do all this, but rather than run in and just sort of attack them and start doing whatever you need to do, just quickly tell them what you're going to do. And if you don't have time to prepare them completely, tell them what you're doing as you do it. You're going to feel like a little bit of sharp something. You're going to smell this. You're going to feel this. Like things like that while you're doing it, so it's not all just sensory overload where they have no idea what's going to happen next. And the encouraging communication with the school is probably not you guys. Coping in adolescence. When asking questions about the teen, ask the teen rather than the parent. Include them in the treatment plan. Obviously, you'll still have to ask the parent, but in that moment, ask the teen. Respect their privacy. Explain things in medical terminology, and then explain the terminology. Keep lecturing to a minimum, even if they're the cause of their hospitalization. You start lecturing, they will shut down, and that's it. Be conscious of a teen's hypersensitivity regarding body image and modesty. Allow them to wear their own clothing if at all possible. Even if it's only, you can wear, shorts under your gown or something. Let them sort of keep some semblance of that. And encourage teens to write, draw, and express their feelings artistically. So to increase coping, focus on providing family-centered care. Promoting the child and family's own coping strategies to deal with hospitalization. Ask the family what their child needs to help them cope with the stress of hospitalization, comfort object, hugs, songs. Promoting optimal development and safety. Minimize disruption of the child's usual routine as much as possible. If you know that every day at this time this kid eats, if that's possible, let them have a snack. Choose your language carefully. Never speak over the child. I see this all the time. If you're on one side and the person you need to talk to is on the other side of that patient's bed, meet them on the other side of that patient's bed if at all possible. Because the kid gets more anxious when they hear themselves being discussed over them. And I mean, unless you're planning on including them in part of the conversation. Strategies and choices. Choices of coping strategies vary from child to child and procedure to procedure. Common choices include sitting on a caregiver's lap, turning their heads away from the procedure, watching the procedure. I'm amazed every day at how many kids want to see what's happening, because I was not that kid. Like, it just wasn't. Holding and squeezing someone's hand, talking with someone to distract them. This is when people who know about, anything kid-related is really good, like talk about cartoons and movies and things like that. Watching TV or a movie, listening to music, and blowing bubbles. If you guys ever need bubbles, I have a lifetime supply. I'm telling you, it is magic. I've never seen anything like it. The most painful things you could ever do to a kid, and you blow bubbles at them, and they don't care. They will play with these bubbles. I didn't believe it when I was in school, and it's true. Increased coping. We can assist the parents in helping the child cope with hospitalization by encouraging the questions. Plan the hospital stay and routine as much as possible. You guys can't do that. It's trauma. Be honest and give the child as much information as developmentally appropriate. Remember, though frustrating for parents and staff, regression is common. I know I'm beating this dead horse, but you will see this a lot. Not every child is developmentally on target to begin with. So treat the child as an individual and don't compare them to other children. Your child may be light years ahead of a child that you see here for various reasons. Sorry. Okay, I'm almost done. One last time. Sorry. So just keep that in mind. Not every child is developmentally on target, and don't assume a child is okay. So a pattern of predominantly ineffective coping strategies during critical developmental period, i.e. childhood, may exacerbate a vicious cycle of repeated failure experiences. Children who have repeated experience of ineffective coping may develop maladaptive syndrome of learned helplessness that may follow them into adulthood. To the extent children experience a sense of mastery, hospitalization can actually contribute to healthy growth and development. So we can make this something that makes them stronger adults if done properly. And that's it. So thank you. Sorry, we lost like 10 minutes because of the